Hello and welcome to today's webinar. It's a pleasure to welcome you on this important topic of adult congenital heart disease. My name is Dr. Carol Warrens. I'm Professor of Medicine at Mayo Clinic and Director of our Adult Congenital Heart Disease Clinic, and I'm joined by my surgical colleague.
And my name is Joseph Dearani, and I'm one of the cardiovascular surgeons with an interest in congenital and pediatric congenital heart surgery and the chair of cardiovascular surgery at Mayo Clinic in Rochester, Minnesota.
So we thought what we would do this morning is focus on what patients need to know in this important population. And we've got some pointers and we'll have some discussion about each of them. And we thought one of the first and most important topics is to talk about access to care. I think this is really important and sometimes overlooked as patients age. It's really essential that you have insurance coverage to make sure that you can get access to care. And it can be challenging, quite frankly. We certainly need more centers and we certainly need more trained cardiologists who have expertise in adult congenital heart disease. I think it's important also to emphasize that transfer of care from the pediatric population to the new medical home of an adult center is very important. Transfer needs to really begin in childhood, but you need to be sure that you have a medical home that you are going to so that you have access to someone who's trained and has expertise in adult congenital heart disease. It's this concept of lifelong follow-up. And unfortunately, transition of care from pediatric to adulthood is not often thought about very well, not often discussed with young patients. And there's this misnomer that's called total correction from the surgeons. In other words, when you have surgery as a child, that surgery may be labeled as total correction. And in fact, I think it's important to emphasize that there's no such thing as total correction in congenital heart surgery. And Joe, perhaps you might like to comment on that.
So from a surgical standpoint, we think of procedures that we apply to anomalies as, quote, corrective procedures or palliative procedures. And in general, there's this understanding that corrective procedures, we try to get the physiology back to what it normally would be. But even doing that, they're really never totally corrected. And they're always going to be vulnerable or susceptible for the need of future procedures because valves wear out, pathways become progressively obstructed, things like that. The palliative procedures are really exclusively helping operations. We are very, very far from the way things normally would have been. And usually we have portions of the heart that are actually missing that result in the inability to get back to where we should be. And then we're exclusively in sort of a helping phase where patients may be left being partly blue or have markedly reduced exercise capacity because they just have sections of the heart that actually were never developed.
So perhaps we shouldn't call the operations total correction. We should call them radical repair or something like that.
Yes, we're helpers and fixers, but never permanently.
Okay, so I think that's an important concept perhaps to emphasize. And so lifelong follow-up is important. And where you get care, again, adult patients are not just big children. They have their own special set of needs and you need to see an expert. And that takes us to message number 2 is the physician. It's very important and guidelines have been published to emphasize this from the American College of Cardiology and the American Heart Association, that the physician you see is trained in congenital heart disease, that they're not just a regular cardiologist, and I don't say that disparagingly, but this is a special set of problems that the general cardiologist is not really expert in. And so the question then comes about, if you have problems, do you need to be seen in a tertiary care center? And you need to get correct advice from your healthcare provider. And I'll give you this as an example. So this is what a normal chest x-ray should look like. The heart is the white shadow in the middle, and you can see the size of it is lined by those yellow arrows. And the red arrows show the size of the whole chest cavity. And in a normal heart, the normal heart size should be about half gravity, and that's what a sort of happy heart should look like. Well, here you see some x-rays of a patient. This one actually has Ebstein's anomaly. And on the left, you can see the x-ray as a youngster. And already you can see the heart size is quite a bit bigger than half of the whole thorax. And as this child grows and becomes an adult, you can see on the right, the heart size is bigger, and it gets bigger yet, and bigger yet. And so finally, when the patient is in his 20s, he has a heart shadow that is huge, very dysfunctional, occupying most of the chest. And then he says to the cardiologist, should I go to Mayo Clinic for an opinion? He was aware that we've published a lot on Ebstein's anomaly and was actually told, no, don't go to Mayo Clinic. They're much too aggressive with Ebstein's anomaly. And Dr. Dearani has a particular interest in Ebstein's anomaly. Joe, would you like to make a comment about this sort of presentation?
Well, I think this presentation is actually not that different than many of the other anomalies that we see in the adult age bracket, where symptoms may not necessarily be present. In fact, patients may actually be doing quite well, and then a chest x-ray like this shows up where the heart is actually quite enlarged. And so there's a false sense of reassurance from the patient standpoint that they're okay. And then we end up with some objective evidence that things are not okay. And then we have the conversation about the role of surgery to try to not necessarily improve the quality of life now, but maybe prolong life overall in general. And Ebstein's is an example of an anomaly that affects a valve primarily. And it turns out that valve problems are the most common problems in the adult age bracket with congenital heart defects. And we can fix some of them. Sometimes they need to be replaced. But I think the important message is that they really need to be evaluated by a congenital cardiologist to determine where the limitations may be. We often hear that patients are, quote, asymptomatic, and then an exercise test is done, and the performance on it is really very, very poor, which to me means they're not really truly asymptomatic, that they really are limited, and perhaps it's not appreciated because it's been so gradual over the course of a lifetime that they don't really have a reference point of what normal could be like. And the typical scenario following surgery is that their quality of life is improved, and you hear comments like, I never really knew how much I was really dragging. Now I can do so much more. And so I think that this analysis by people that really know this information and are doing it day in and day out can really help coach and navigate and advise people in the right direction.
It's an important concept, isn't it? Because people believe themselves, how can there be anything wrong with me because I feel okay?
Right.
And then you see x-rays like this, you see ventricular dysfunction, the risks of surgery go up significantly.
Right. And this brings up another point where sometimes the anomaly was recognized in childhood and surgery was performed in childhood, maybe more than one operation in childhood. And so it's not that alarming then in the adult years to find out that they may need something else. But then there is a whole nother set of anomalies that don't appear until adulthood. They sort of snuck through the childhood years. Murmurs weren't present. They were feeling quite good. And then on a physical exam, maybe a murmur's heard, maybe not, or a routine chest x-ray gets performed. And then you're stuck with, wow, we didn't know that this was going on. So
how can I have congenital heart disease?
Right.
I'm 50 years old.
Right.
Yeah.
And there are many
Absolutely.
operations where the very first operation is not done until the adult years, and sometimes not until the middle adult years.
In fact, in our practice, half of the patients who come to Mayo Clinic have never had prior surgery.
That's right. And the vast majority of them feel much better after surgery. Right. So we really need to figure out who should be treated and who shouldn't and what the treatment should be.
So it's a concept of operating before ventricular function deteriorates even further, because then the risk of surgery will go up even higher.
Yeah, I think the main risk of surgery for any cardiac surgery, it depends on the function of the heart. And when the function of the heart is good, the risk of surgery generally falls into a low category. When the function of the heart is poor, it generally escalates to a higher category. And then there's the number of previous operations. These are probably the questions that I get asked most frequently. And depending upon the nature of the previous operations, actually the fact that there's been a previous operation really does not increase the risk of subsequent surgery dramatically until you get to the fourth, fifth, sixth operation.
Inexperienced hands.
Inexperienced hands, yes.
So we'll move on to another topic. These are important points, I think. Number 3 is your anatomy. I think it's important that every patient has to understand exactly what they have, what the name of the lesion is. Sometimes there's a name attached to it, or the name of the operation that you had. And I can tell you, it's not uncommon that we get calls from emergency rooms saying John Smith is in Mississippi or somewhere in an emergency room, and they don't know the name of their lesion or their operation. And it really is important that you understand all of those concepts. Some have even suggested that you have your own passport to delineate what your current situation is, what your current imaging data shows, and what operations you've had and when. So it's up to you to take responsibility for knowing all of that and understanding it all. Also, importantly, are the non-cardiac issues. How much can you exercise? Can I drive the school bus? What about non-cardiac surgery? For most of us, these things are routine, but if you need an appendix out, for example, some patients with complex lesions need to go to comprehensive care centers where that can be performed with the whole team who's involved with their congenital care following along. And pregnancy also is one of those important issues. 2% of pregnancies involve maternal cardiac disease, and most of them are congenital. And the good news is that most women with congenital heart disease can have a pregnancy with proper care. But of course, there is an increased risk to both the mother and the baby. And the key really is having a pre-pregnancy evaluation by one of these experts. And you need to know, and it's very much individualized, what's the risk to the mother and what's the risk to the baby. And this is a brief sort of list of the kinds of things that you need to be advised about and ask questions about. So I have congenital heart disease. What's the risk of my baby having congenital heart disease? Important genetic counseling. Am I on any drugs that might potentially harm the baby? If I elect to go ahead with the pregnancy, where am I getting care? Where am I getting my cardiovascular care? Where's the obstetric care? Is it in the same center? Do I need to be in a center where both are available? And you need to have a plan in place for monitoring the baby's growth and development, for monitoring labor, for monitoring postpartum care, and importantly also for those women who are unable to have a pregnancy, getting proper advice about contraception. So there's a number of things you need to know about. And this just reminds us that this graph shows that in the first, second, and third trimesters of pregnancy, your heart is going to have to withstand an increase in volume. You see that yellow bar demonstrating an increase in plasma volume, which round about the middle of the second, third trimester goes up by about 50%. So your heart has to withstand that volume load. And so your physician needs to advise you about that. And you can imagine that if your ventricles here shown in a normal heart on the bottom, these pumping chambers at the bottom, if those ventricles aren't working normally and they have to have a 50% volume load of pregnancy, there are risks of things like rhythm disturbances and heart failure during pregnancy. So bottom line, you need to get appropriate advice. Your pressures in the ventricles are very different. The right ventricle normally pumps at 25, pumping to the lungs. The left ventricle, pumping to the body, pumps at a pressure of about 120 in a normal person. But if those pressures in those chambers are higher for various reasons, either because of a valve lesion, for example, or pulmonary hypertension, again, you're vulnerable to complications during a pregnancy. So see your doctor before you embark on a pregnancy. And there are groups of patients that pose particular risk. If you have pulmonary hypertension, for example, especially with blue heart disease, cyanotic heart disease, the risk of a pregnancy may be formidably high. If your pump function is depressed, if you have an ejection fraction, the squeeze of your ventricle is less than 40%, you may not be able to withstand that volume load of pregnancy. If your aortic root is dilated, for example, then the changes, the hormonal changes of pregnancy may make that aorta more fragile. And last but not least, if you have mechanical heart valves, managing anticoagulation during pregnancy needs to be meticulous, and it's fraught with problems, and you need to make sure if you embark on a pregnancy, you get special care.
So maybe a couple comments about pregnancy from the surgeon's standpoint. Your plea and great deal of emphasis on planning is critical, because once we get into trouble during the course of pregnancy, if we didn't have the ability to plan appropriately, poses considerable challenges for the surgeon. I mean, while we can operate on a woman who's pregnant with congenital heart disease, the risk of surgery is increased. It may be safer, but there's a risk to the mother, there's a risk to the baby, and of course it creates enormous anxiety and stress for the mother and everybody. Mm-hmm. Everybody. So planning in advance, and there have been many situations where we've shared patients where you have a young woman who is approaching the family planning years, and they want to have everything looked at to make sure, and there are many situations where we actually do surgery to prepare them to get through pregnancy safely after they've recovered from surgery. And it's always better to do it like that, if we can, than to have it go unrecognized and then have to deal with the challenges that occur during the course of right in the middle of the pregnancy.
Yes, fortunately it doesn't happen often, but sometimes we've been faced with women with thrombosed prosthetic mechanical valves that we have to operate during pregnancy and so on. And it's a tragedy because often they've been given wrong advice about how to manage their anticoagulation during pregnancy. And I've seen it from both sides. I've seen women who have had minor heart lesions who were told you can never have a pregnancy, and I've seen it the other way. And you really need to see somebody who's an expert in both managing pregnancy and adult congenital heart disease.
And I will say, while I am fortunate to be around a lot of experienced cardiologists, both congenital and non-congenital, I have been very, very impressed with this particular group of patients where it really requires a very, very focused. There's not many cardiologists that really understand the nuances and subtleties of congenital heart disease. There have been situations myself where I thought it might be okay for a woman to get through pregnancy, and for very obvious reasons to somebody like you, it clearly is something that should not be the case, and vice versa. So it really requires somebody that has insight and knowledge about this to really advise accordingly. So
and getting the whole team, the geneticists,
exactly,
high-risk maternal-fetal medicine team, so that a woman can make proper informed advice before they embark on a pregnancy and then potentially have a disaster. So we'll go back to the last topic, and that's the surgeon. And I'm going to pick on my surgical colleague here again. I think it's very important that we emphasize that the surgeon is trained in adult congenital heart disease, obviously has a lot of experience. And again, we embrace the whole multidisciplinary team to make sure that the patients get through their surgeries successfully. I know in our practice, 40% of our patients, for example, are having operation number 3 or higher. So we've been faced with patients having redos, as you mentioned earlier, operation number 5, 6. But would you like to comment on this whole team approach and the kind of disciplines that need to be involved in getting patients safely through surgery?
So there's increasing evidence in the literature that the outcome of patients with congenital heart disease in the adult age bracket is optimized when the people taking care of them are trained in congenital heart disease. And historically, and it still is the case for surgery, it's a little bit different for cardiology, but for surgery, we now have a certificate for surgery for congenital heart defects. And most of the exposure during your training, which is after a cardiac and thoracic surgery residency, so we're really getting out there in numbers of years of training, focuses on surgical treatment of congenital heart defects in children. And now it's becoming more appreciated because we actually have more adults with congenital heart disease than we do children.
More than 1 million.
More than 1 million.
In North America.
And part that is in part due to the great successes of cardiac surgery from the earlier eras in the 60s and 70s. And then in the 1980s, we started doing surgery in newborns. And so now we have all of these patients that are surviving well into the adult years, and then they have a recurrent lesion, or they have a valve wearing out, or one of these other problems that requires attention. And so for training now, there is an expectation that during the course of your pediatric and congenital training, you are exposed to a certain percentage of adult congenital heart defects. But be it as it may, adults with congenital heart disease that require surgery, a congenital surgeon generally is usually the one that's directing the surgery, with or without the help of or collaboration with an adult cardiac surgeon. For example, a complex congenital heart anomaly that requires bypass surgery in addition to fixing the anomaly. There are some surgeons that may be comfortable doing both, but there are many that may not. And so the congenital surgeon would fix the congenital defect. The adult surgeon would then do bypass surgery, which they are doing every day. And the importance of this interface and collaboration is really what the patients need. And
it's the same from the medical perspective, because of course patients will also have acquired disease. All the things we're all vulnerable to: the coronary disease, the hypertension,
the diabetes,
all of it has to be managed together. So each has an impact.
It's a multidisciplinary approach, and but the people being most important is critical. And where it's done is less, as long as the person, the nuances from city to city or practice to practice in terms of a children's hospital versus an adult hospital, there are going to be local situations that will dictate. I mean, in one situation, it may be better to take care of the adults at a children's hospital, and in another city, it may be better to take care of the congenital patients in an adult hospital. But it's the personnel that are looking after them, which is really the key to success.
The whole infrastructure, team multidisciplinary care.
It's just everybody's got to go over to the other hospital and take care of them, which we do.
Okay, so last we'll come on to the topic of education. And I think this is important too. Again, I think patients need to be educated about every aspect of their care. Don't get advice, as you've heard, from people who don't know. Don't get secondhand advice from another patient. Do research, go online. The Adult Congenital Heart Association support group may be very helpful, giving you resources and education tools to help you. But I really think it's important that you yourself get educated and be your own advocate. So I guess to summarize what we've been saying this morning, I think the very best care for patients, which is what we all want after all, is that you are seen by somebody with knowledge, training, and expertise, and you need to be sure that you're attached to a special center where all of that's available. And it can be challenging. Sometimes there may be obstacles that may block your path, insurance and so on, but really go on the computer, go online, search out the data. There is much published about where centers are, and to get the very best care, you need to be seen by experts, both in the medical team and the surgical team. And you need to have a good liaison with your local physician. Local physicians and cardiologists should have access very easily to adult cardiologists at special centers. This is a sort of group effort to ensure good survival. You have a local contact, and your physician ought to be able to pick up the phone and call somebody and get prompt advice from an expert to ensure that you get proper care.
Yeah, I think this is a great slide, because one of the things that I am confronted with is when a patient comes here, they start to get attached to some of the practitioners that they have here, and they may live, quite a distance away. And it's important for them to have a good relationship with their home physician, because the dialogue that occurs between their home physician and the physicians here will always be ongoing. And they want to have somebody that they have confidence in at home for sort of general basic kinds of care. And then when we get into a situation where big decisions need to be made, is an operation going to be necessary? Am I going to be able to get pregnant? Do I need to do this? Then, then I think some of the subspecialists can then get dragged into the equation. So I do think that this triangle of communication is an ongoing thing that needs to be emphasized, that there isn't a detachment of dialogue once they go home, and then we're out of the picture, or when they're here, their home doctors are out of the picture. It really needs to be a continuous communication so that the patients, and I think that this webinar is actually a classic example of patients educating themselves. And in the current era with the power of the internet, you know, the availability of information and knowledge is exhaustive, and it's just a matter of being interested in searching it out. And I think this is a beautiful segue into questions for the patients, because we are all educating each other with this kind of a format. So
at that point, we'll be happy to take questions from the audience if you have any.
So the first question is regarding actually a child that has an anomalous coronary artery, and the question has to do with the advantages of surgery and the age and who should do it. And let me first begin by saying that this anomalous coronary artery that's being referenced here is becoming a more common finding than we once thought, mostly because imaging is being done for other reasons and it gets picked up incidentally. And it will be difficult to give specific advice about this patient here, but I would suffice it to say that there are many situations where this anomalous coronary artery should be treated surgically. The right one is the controversial one. And the proper age is variable. There are situations where we would do it in childhood, and there are certain situations where we would not do it at all. And usually the congenital surgeon, again, it's a congenital anomaly, usually the congenital surgeon is the one that would typically be managing this. So this particular question, I think, needs to be individualized in this situation. At 3 months of age, almost never we would do anything about this. If something needed to be done, it would be much later on in life. And that would be at least what I would say. I don't know if you want to add anything to that.
And many patients with this anomaly actually never require surgery. It's a surprisingly common anomaly. We didn't used to realize it years ago, but as Dr. Dearani said, because of the frequency, particularly of CT imaging now in many adult patients, we discover coronary anomalies when patients are 50, 60, 70. The right one is quite controversial, as he mentioned, and the approach really needs to be individualized. The next question relates to pregnancy, and it's a patient who's 30 weeks pregnant, and there is some degree of narrowing or stenosis in the aortic valve itself, and the aorta has dilated almost to 4 centimeters. And the patient is seeing someone who doesn't seem to have a lot of experience with congenital heart disease and pregnancy. Maybe going in Canada to Vancouver. I know there are special experts in Vancouver. I know some of them. Again, here there's some important things. The question is, what's the suggestion in terms of pregnancy and labor management? So number one is, what's the degree of aortic stenosis? If this aortic valve is mildly or moderately narrowed only, and the patient has had a good exercise capacity and no symptoms, it may be that pregnancy can be managed pretty safely, again, usually in a special center. And with this aortic root that's dilated, if it's 3.9 centimeters or 4 centimeters, that is not to the degree that we worry considerably about the aorta having a tear during pregnancy. So the key here is, how severe is the narrowing across the aortic valve, and that would determine where pregnancy and delivery should be carried out, and what kind of delivery you should have, i.e. a vaginal delivery versus a cesarean section. If there's a lot of aortic stenosis, if the valve is very narrowed, it absolutely would be very important that you are delivered, again with the whole team approach, in a special center where cardiology, maternal-fetal medicine are all together managing you carefully. And then you want to avoid a long labor, and in some circumstances, the baby may need to be delivered early, and that in and of itself may mandate a cesarean section. If the narrowing is mild or moderate, it may be that you can have a vaginal delivery safely. So again, it has to be individualized, but certainly I'd recommend that you go to a center where there's considerable experience in congenital heart disease and pregnancy both.
The next question has to do with a middle-aged woman that has transposition of the great arteries and had a mustard operation. So the systemic ventricle is the right one, the incorrect one. And there's been the development of heart failure over the last couple of years, and what would be the prognosis? Well, this would be hard to know which way things could go here. I mean, there are situations that, first, this is the natural history of this operation, that over time the ventricle will eventually start to get progressively poor function, and symptomatic heart failure will develop. Now, the heart failure may be related to arrhythmias. It may be related to a valve leaking a lot inside the heart. It may be related to the function of the heart progressively just having gotten worse. So in terms of prognosis, it's there obviously are not enough details here to tell you, but it could range from, you know, implementation of a medical program that could improve quality of life, all the way to the other end of the spectrum where transplantation might need to be considered. And then, you know, other things in between, procedures to open up pathways that may be blocked, valve surgery for valves that are leaking. So there could be many things that could be possible here, and it really would require review and analysis by somebody like Dr. Warrens or an adult congenital cardiologist who can really piece the information together and really determine whether or not there's a place for medical therapy, surgical therapy, or whether we need to be thinking along the lines of something much more radical like heart transplantation.
And again, I think that's important. I hope this patient's being seen at a special center to get informed advice. Controlling things like blood pressure can help treat heart failure. Some medical therapy may help. Sometimes even more innovative initiatives like biventricular pacing can be helpful to treat the heart failure. So those kinds of initiatives can be really, really helpful. Maintaining an ideal weight, maintaining normal rhythm, because if the rhythm goes out in this situation, and commonly arrhythmias are one of the issues that's written into the natural history of this condition, maintaining normal rhythm is really, really important. The next question relates to someone with 2 VSDs and a patent foramen ovale and the benefits of surgery. Joe, would you like to take that one?
I don't know how old the child is, but there are some VSDs that will close spontaneously during childhood, and usually if that's going to happen, it happens within the first year or 2 of life. There are other VSDs, because of their position or because of their size, are too big, and they will require closure. The risk of, I mean, this is sort of a benchmark operation for pediatrics. I mean, VSD closure is a bread and butter operation for a pediatric heart surgeon. The risk of surgery is generally less than 1%. The incidental finding of a patent foramen ovale, a PFO, that's not the important variable here. It's the VSD. And if there's any question about weight gain or failure to thrive or issues that would point to the VSD, it should be closed. Most of these are done surgically. There are some less invasive ways to do it in the current era. Again, that depends on the location of the VSD and the size of the VSD. But this should be looked at by a pediatric cardiologist. The decision whether or not to operate should be relatively black and white. It shouldn't really be tricky or complicated. This is a straightforward problem that usually has a straightforward solution.
And the PFO may need no attention at all unless there's a complicating feature. So that's a little hole in the top 2 chambers, a patent foramen ovale. And that's in about 30% of the population. I may have one, you may have one, right, for all you know. So that usually in and of itself doesn't require any attention. And the next question is, I'm 30, I have 3 children with mitral valve prolapse with regurgitation, and has the doctor said that the patient needs to be checked every year, but hasn't sent me to a cardiologist. I think you can ask to be referred. The question is, should I seek one out on my own? And I think you ask to be referred to a cardiologist if there's any doubts about how severe the leaky valve is. And usually a doctor would know a good cardiologist in their group that they could refer you to for an assessment.
And probably the only other thing to add to that is that there is evidence now that severe mitral regurgitation in an asymptomatic patient, there are benefits with surgery in the long term with that. And so we don't know the degree of regurgitation in this particular question, but this is, again, something that in the event that it does need surgery, it can be done minimally invasively. Actually, it can be done robotically. The recovery is rather quite short. The risk of surgery is exceedingly low. And I would say that you should be evaluated and determine whether or not it's premature or whether or not it's something that requires treatment.
The next question relates to foods or healthy habits which can reduce congenital heart diseases. I don't know if this means in the baby or in someone who already has congenital heart disease. So just a reminder that almost 1% of babies are born with congenital heart disease. And for some of these, we know there are genetic reasons that the baby is born with congenital heart disease, but we certainly don't know all of those. Sometimes the mother might have been exposed to a virus when the baby was in utero. Smoking may have an impact. Caffeine and alcohol and drugs obviously can have an impact that will increase the chance of a baby having congenital heart disease. But in general, it's impossible to say that there are specific foods that would reduce the incidence of congenital heart disease. Having said that, if you've got it, it's very important that you remain healthy. I mean, you need to maintain an ideal weight, have a regular exercise program, make sure your blood pressure is under good control. Obviously, there are unhealthy habits which can make your congenital heart disease worse. And the last thing we want, as we talked about before, is getting acquired heart disease, getting hypertension, coronary disease, and the things we're all vulnerable to. So healthy lifestyle is also really important.
The next question has to do with advancements in the field of minimally invasive valve replacement. This is a great question because there actually have been substantial advancements in the current era. Now, minimally invasive valve replacement means different things to different people. It could mean a catheter-placed valve with no incisions anywhere, or it could mean robotic valve surgery, or it could mean a mini incision doing a standard heart operation. But I think the point here is that there are a lot of minimally invasive approaches for certain valve problems, and it's individualized. If there's been multiple previous operations in the past, it's probably not likely that there's going to be a good minimally invasive approach. But if it's the first operation, depending upon the valve, depending upon the body habitus of the patient, generally thin, trim patients are much easier to do minimally invasive approaches in contrast to patients that are markedly overweight. You should make sure that you visit with a surgeon that has experience with this, because I think that would be something that's potentially an option.
So the next question relates to someone who's got a repaired atrioventricular canal defect and has a mechanical mitral valve that's been replaced, and the patient's been told that there's absolutely no way that they could have a safe pregnancy because of the mechanical valve, and the patient's just been told by another cardiologist that a mechanical valve does not mean that a pregnancy is completely impossible. So this is a very complicated question, and you need to have a long discussion with your healthcare provider. I can tell you, in essence, the bottom line is the major issue, again, two things to consider: the risk to mother and the risk to baby. So if you have a mechanical valve, you're taking the blood thinner Coumadin or warfarin, and that has a potential impact on baby's development within the first trimester. And that might mean, if the baby is exposed to warfarin or Coumadin, depending on the dose that you're on, that baby is vulnerable to being maldeveloped, poorly formed, with various congenital defects that can involve the brain, the eyes, the nose, the skeleton. And so the risk to the baby in part relates to the dose of Coumadin that the mother's on. Now, in an effort to avoid the baby being exposed to Coumadin or warfarin, that blood thinner, it is possible to change the anticoagulant, particularly in the first trimester, to heparin. And one of the heparins that's used nowadays is low molecular weight heparin that has to be given by subcutaneous injection. This is a big problem because the challenge with heparin is that it's not such a good anticoagulant as warfarin. And so you need to inject yourself carefully, and you need to monitor blood thinning very, very carefully and in a meticulous way, at least every month, every week, if you go ahead with that sort of strategy. And even if you do it in a very meticulous way with the best centers, and you inject yourself regularly and the doses are adjusted, the risk of having a clot, a thrombosis on the valve, is at least 10%. And in some even good series, the risk has been as high as 17%. So you're faced with this sort of dilemma of having the risk to mother, of having a valve thrombosis, which might require emergency surgery, might result in a stroke or even death, versus a risk to the baby. So this is a dilemma. It's been called a sort of double jeopardy. And if you decide to embark on a pregnancy, you need a discussion. What's the risk for me? And again, it depends on how's your valve functioning. It sounds like the ventricular function, the pump function in this situation is good, but it depends on the dose of Coumadin that you're on. What's the decision that's right for you? And what's the valve gradient? And can I be seen? Am I willing to be seen at a center and have blood tests every single week of the pregnancy? And you have to acknowledge that there are risks. And if you continue Coumadin throughout the pregnancy, the other issue is that that is associated with an increased risk of miscarriage, placental bleeding, and bleeding in the baby. So it's not impossible to answer the question specifically, but it's a major undertaking, and there are very special risks that you need to be aware of. And we've done it, every big center does it, but it's a risk that you need to be completely informed about. And a lot's been published about this in the last 3 years. So there is new information, and there's much online. We actually just published a paper on this in the journal Heart, looking at these. So make sure you see somebody and get all the current information before you embark on a pregnancy. It's different from 8 years ago. It's all changed.
The next question has to do with an anomalous circumflex coronary artery and myxomatous mitral valve disease with prolapse and mitral regurgitation, and the concerns related to surgery. Is it serious enough? What should I do, and what is there any relation to sudden death? Well, myxomatous mitral valve disease is a common problem, in the developing world, and the treatment of it when it becomes severe, even in asymptomatic patients, as we alluded to earlier, is generally to fix the valve. There is a survival advantage if you take it out of the equation. And in isolation, if this is the only problem you have, it can be done minimally invasively in many patients. Now, I don't know the details of this anomalous circumflex coronary artery. There are innocent sort of anomalies that you don't need to do anything about, and there are anomalies that may also create some worry. The sudden death thing, there actually is a small incidence of sudden death with mitral regurgitation. It's very different than it is for aortic stenosis, but it's generally low, and there is a risk of sudden death with some of the anomalous coronary arteries, and I don't know enough about this particular one to know whether that would be a concern. But what I would say is that this appears on the surface that it's relatively straightforward, and we have standard operations that have been done for decades for this combination of problems, and I think you need to be seen by a cardiologist that is knowledgeable about this, and then a decision should be made. The risk of surgery generally is very low, 1% or less for this, even in a 60-year-old. So I would not keep putting it off. I would be seen by somebody who knows, who can advise you accordingly, and then move forward.
The next question is about surgery. Joe, I don't know if you want to take this one. A 15-year-old with transposition, pulmonary stenosis, and a VSD who's about to have open heart surgery and the double switch procedure. You want to talk about that?
Well, the transposition pulmonary stenosis DSD complex is it's a complicated anomaly, and actually one of the initial operations that was ever done for this anomaly was actually done right here in this institution. And over the course of the last 40 years, operations for this have evolved somewhat, and the double switch is sort of the current operation that's in vogue for it. I would say that in the very young population, in the first 5 years of life, most would agree that the double switch operation for this anomaly, usually there needs to be an element of congenitally corrected transposition. So I suspect that the way it's worded is maybe just slightly inaccurate, but is generally considered, the operation that most would do. And in the adult population, the double switch operation is generally not advised. And in the teenagers is where it becomes very, very gray. When you look at the reports of the literature, the risks of the double switch operation, usually there's a breaking point in the teenage years where the risk of surgery starts to go up. So in this particular situation, with it being a 15-year-old, I think if the double switch operation has been advised, it must be that the anatomic features are putting her more on the favorable side. But this is the age bracket where there tends to be more controversy. The young patients, younger than that, in the first 5 years of life, it's much more commonly accepted. And in the adult years, it's generally not advised. And in this sort of middle age bracket is where it sort of could go either way. So I guess my advice would be to make sure that the team and the surgeon in particular that is going to be doing this is highly experienced with it, because this is a gray area with this age bracket. Would you have anything?
No, I would agree.
Yeah.
The next question relates to advice about exercise and work. Again, I think this needs to be very much individualized. For exercise, it really depends on the lesion. As I mentioned earlier, generally, we like people to be maintaining a really good exercise program, which should involve aerobic exercise. For most congenital patients, we like to advise against heavy lifting, and that cutoff, depending on your gender and your size, is often around 50 pounds. Some guidelines are about to be published about exercise in this situation, and often we advise against competitive athletics, but there has to be a good balance, I think, in the middle between doing a regular aerobic exercise program, doing what you enjoy, being on a treadmill, cycling, swimming, if you like to do that, maintaining healthy blood pressure, healthy lifestyle, healthy cholesterol, and so on. But heavy lifting generally is the one concern for really two reasons, because if you really start to do anaerobic exercise when you're straining, your blood pressure can go way up. If you've got a fragile aorta, you can tear an aorta, arrhythmias can develop, little cords on valves can rupture. So strenuous lifting should be avoided. And for work, again, get advice from your cardiologist. Generally, we like people to maintain a normal, healthy, active lifestyle and work as much as their congenital heart disease will allow them. Now, sometimes that we have to put constraints on that, because some patients who are obviously fragile might not be able to work on a regular basis. But fortunately for most people, they can enjoy a healthy, active lifestyle and work on a regular basis.
Well, the next question it touches on a lot of things that Dr. Warrens and I have alluded to in all these discussions. My daughter will be 38 years old this year. She has atrioventricular septal defect that was repaired when she was an infant. She's done well, but she has some problems with the mitral valve that are advertised as moderate in nature, but it causes her no problems. She has been told that there's no rush to repair or replace this valve because she is doing so well. So a few comments here. First, this is a parent talking about their 38-year-old child, and I think that it's very, very common for parents to still be engaged at even with their children when they are well into their adult years. This is a lifelong investment. This is a classic anomaly where more than one procedure is frequently required over the course of a lifetime. We salute all of these families out there and with their parents and siblings who have weathered a lot of anxiety and a lot of procedures and a lot of access and exposure to a hospital environment, which we recognize is not easy. Now, the question has to do with whether or not anything should be done because the patient is doing so well. And this goes right back to, I think, what we were talking about earlier, in that I don't know whether it's okay to just not do anything at this point. And it really requires a review and analysis by someone like yourself, Dr. Warrens, to really look, because patients can do notoriously well and still have some really very abnormal pathology where we would advise surgery, even in the face of feeling well, so to speak. So I think that if the problem is truly just moderate in nature, chances are that nothing needs to be done right now. But I think that determination needs to be made by somebody who really knows these lesions, because if it's a severe problem, the recommendation might be completely different in terms of advising surgery or maybe being on some kind of a medical program if the problem is a leaky valve as opposed to a narrow valve, etc. So again, insight from somebody who knows is going to be your safest course of action, because this question could have many answers depending upon what really is going on, and a more detailed analysis with imaging and echoes and so on will really help guide the proper care.
We go back to that chest x-ray. Is the heart size normal on chest x-ray? How big is the ventricle on the imaging, the echocardiogram? And is it really moderate? Is the clinical exam consistent with what the echo says, that the leak is only moderate?
Right.
And perhaps it deserves emphasis that even though the patient's had prior surgery, sometimes these valves can still be repaired. They don't automatically need to be replaced in experienced hands, even at the age of 38 or older. They can still be repaired quite often. So again, the approach needs to be individualized, and these other testing, including an exercise test, would be helpful.
Here's a question about a patient with Ebstein's anomaly that has already had surgery and has mild to moderate residual regurgitation, so a good result. This was a few years back, and the question now has to do with safety of proceeding with pregnancy. And then, if so, what would be the strategy for delivery in terms of C-section or vaginal delivery? So I don't know, Dr. Warrens, maybe you want to take a swing at that.
Yeah, we've actually published some data. We've got quite a large experience of patients with Ebstein's who've had surgery having pregnancy. And the good news is that as long as the valve is only leaking mildly to moderately, if you can do a good exercise test and the right ventricle still has pretty good function, then the chances are you can have a pregnancy safely. And very commonly, people imagine that you have to have a cesarean section because you've got congenital heart disease. In fact, that's not the case. A vaginal delivery very often is quite appropriate. We don't like, having said that, women being in labor for a very long period of time. We don't want you being in labor, huffing and puffing for 36 hours. That's a big burden on the heart. But many women with Ebstein's who've had successful repair can have a pregnancy. We usually offer a fetal cardiac echo at about 22 weeks to see whether the baby has any congenital heart disease, because if there's no other congenital heart disease in the family, the risk of a mother with Ebstein's having a baby with Ebstein's is only about 4%. It's not that high, but usually we can screen and reassure mother that baby doesn't have any congenital heart disease. But as long as those things are good, the valve is working well, the right ventricle is happy, no rhythms, no drugs that might affect the baby. Again, that detailed evaluation pre-pregnancy, but I'd be optimistic, at least based on this story, that a pregnancy could be accomplished successfully.
The next question has to do with a 1-year-old that has peripheral pulmonary artery stenosis, and there's been discussion back and forth about surgery, I suppose, versus a percutaneous approach, and what's appropriate, is a second opinion in order, wait till she's older, etc. So this is, again, we won't get to a definitive answer to this question, but there would be a few general principles that I would say should be considered. The first is that peripheral pulmonary artery stenosis, that to me implies that it's out very close into the parenchyma of the lungs, and in that situation, there really is no role for surgery, particularly in an infant when that's that far away from the heart. When it's much more proximal, close to the heart, the right and left branch pulmonary, the main pulmonary, there is very much a role for surgery, and the results with surgery can be really quite gratifying, and they can be very long lasting. The second thing about this question that I think deserves maybe just a short comment is that, pulmonary artery stenosis in isolation is a little unusual, and oftentimes it occurs in the setting of a syndrome or something of a more complicated, cardiovascular anomaly. And so I think that also would need to play a part in terms of the timing of what should be done, because there may be another lesion elsewhere that is associated with this that might require surgical attention. And if that's the case, then an effort maybe to patch the pulmonary arteries, at that time might be considered. So it's always easier to do things when they're a little bit bigger, but again, it depends on the nature of the particular problems at this juncture. I mean, if the child is not doing well, then it's likely that something would need to be done now. Percutaneous approaches is probably the more mainstay for pulmonary artery abnormalities. Again, it depends on the nature in terms of whether it's discrete, can it be dilated, does it need a stent, etc. This, again, emphasizes the importance of a multidisciplinary approach, a cardiologist that can put it all together, an interventional cardiologist that has experience with this, and a surgeon that also has experience with it, so that, in one program you can get a thorough analysis with a good recommendation.
And the next question, we're back to the right coronary artery anomaly. There seem to be a lot of those out there. So this is when the right coronary arises from the wrong part of the aorta. And this is referring to a baby who's 2 months old. And again, I think we should just underscore the approach needs to be individualized. The vast majority of patients who have this anomaly do not require any surgical intervention, particularly if they're asymptomatic. And we have patients who we've seen who are 60 and 70 that have had no surgical intervention. So unless there's a good reason to intervene, and Joe, you might want to comment, this baby's 2 months old, typically we would not intervene unless there were worrisome manifestations. Pregnancy may not necessarily be a complication as you get older. In fact, there may be no complications at all. So this is such a common lesion, as we've now learned in the last 5 years, that not everybody with an anomalous right coronary is going to need an intervention. In fact, the vast majority won't.
That's right, and particularly in an infant. I mean, it would be very, very, it would be very unusual when you look at the reported series of unroofing of anomalous coronary arteries. It's exceedingly rare that it be required in an infant, particularly with an anomalous right coronary artery. So, as you said, I mean, most of these, may not need anything done, and if they do, it's usually much later on in life with clear evidence of ischemia or a problem or symptoms that's really pushing you to do it.
Right. So I think we've underscored a benign prognosis for the vast majority of patients with that anomaly.
Well, I think we've had a great series of questions, and I think that I think our time is running out here. But I think I would just like to congratulate the audience. It's been a stimulating discussion, and there's been a lot of great questions that have been asked, and I think that this is what we want. We want patients with congenital heart disease to really submerge themselves in with the details so that they know what they have, they know who they should see, and they're gathering information, because the outcome of all the management of all of these problems is always better when everybody has insight than I think of a knowledge base that goes beyond the medical community and gets right into the patient community, because this is how I think care is optimized.
Absolutely. So, I mean, the Adult Congenital Heart Association provides resources. I think we're able to take questions at the conclusion of this webinar. People are able to write in and ask us questions. And one of the questions related to, is it okay if I get a second opinion? You and I get asked for opinions all the time, and I think it would be important to emphasize to patients, if they say to us, can I get another opinion? We have to be okay with that. There shouldn't be a problem, I think, with any physician or any surgeon. If you're comfortable with your opinion, your decision, If a patient says, do you mind if I go somewhere else and get another opinion? That's fine. We'll send the data to whoever you want to see. We can even make some recommendations. But don't be afraid to say, is it okay if I get another opinion? We should be pleased that you want to be informed.
And I think just maybe two final remarks is that the American College of Cardiology and the American Heart Association, we are in the revision of guidelines for the management of these defects, which I think will be helpful to the medical community as well as the patient community. And then finally, I think just to emphasize what Dr. Warrens is saying is that in the adult population with congenital heart disease, there are many situations where it is not a black and white decision in terms of what is the best way to go. And that emphasizes the importance of soliciting input from others anyway. I mean, we may be doing it offline with our own peers, either internally or externally, when we have situations where it's really not clear exactly, should we go after it now, or should we sit on it a little bit longer? Should we do something temporizing in the cath lab? Should we buy a little bit of time on medical therapy? So the importance of gathering input from others with knowledge of this is, I think, more helpful than not.
So thanks again for joining us today. We're delighted to have you, and we look forward to getting more questions. Thanks again.
Thank you very much.